Yes, sir.
2, 1. Please start, sir. We are live.
Yes, sir. So, good evening to all. Good evening, all respected doctors. Good evening, Prashanth Sankar, sir. So, we are very happy today that we are having Dr. Prashanth Sankar as our speaker for the program, that is Clear Talk. To mention about Dr. Prashanth Sankar, doctor has done his MBBS from Government TDB College, Alappuzha. Thereafter, his MD from Government Stanley Medical College, Chennai. And his MRCP, UK, London, FRCP from Edinburgh, fellow in, and doctor is a fellow in diabetics, that is Diabetic India, 2003. Lead International Medicine and Diabetic Department of MGM Muthoot Hospital, Patnamthitta since 2011. Doctor has presented original research work in ADA and IDF conference, including more than 15 research publications. Doctor is a joint secretary of API Kerala chapter and IMA Patnamthitta, governing body member of RSSDI Kerala chapter, and a faculty in family medicine and Dependent internal medicine. Doctor has the annual doctor has received the annual Diabetic Tech Innovation Award, that is JPF USB in 2022, JC Agro Shastra Award in 2021 for the outstanding contribution and achievement in healthcare, and Diabetic India Best Diabetic Awareness Initiative Award in 2017. And Doctor is a regular invited faculty at regional and national conferences of internal medicine and diabetics, has delivered more than 300 lectures in various academic sections, and is a founder and secretary of PADM 4 Foundation, Professional Alliance of Diabetic Internal Medicine and Allied Specialties. And Dr. Prashanth Sankar's clinic, that is FB page since 2015, is spreading diabetic awareness throughout social media, which we are all aware of. And once again, I welcome Dr. Prashanth Sankar to open the deliberations. Thank you, Doctor.
Thank you, Suresh, for the kind words of introduction. I will just share my slides.
Yes, sir.
Once again, I welcome all the attendees to this evening lecture, which is termed as Clear Talk Meet, basically which talks about the one of the latest trials with the new kid on the block with respect to management of dyslipidemia, that is bemdac acid. And it's based on the findings of the CLEAR trial. And we'll be looking at bemdac acid through the lenses of the CLEAR outcome trial. So this is the status of LDL cholesterol. Lower is better for longer. So that's based on all the research which has taken place over these years. Multiple research has been done on the levels of cholesterol with multiple agents. So what all these agents have shown is that lower the levels of cholesterol, lower is the risk of major vascular event, and higher is the relative risk reduction. So from an LDL of 100 or 130, which is considered to be normal a couple of decades ago, we have come down to 100, then to 70, then to 50, and now even 40 or 30 LDL is considered to be significant in patients at high risk or very high risk of getting a cardiac event or atherosclerotic cardiovascular event. So that is all these things are based on clinical evidence and huge multi-centric trials which has been done at across the globe, and all the trials have shown the same thing. And as the treatment has advanced, what we know is that the drugs are much safer, and we have multiple options in patients who are not able to take the conventional drugs, or somebody who is not tolerating the conventional drug. We have multiple agents to support that the treatment, so that the patient reaches the target which is meant for the particular patient. So each 1 millimole reduction of LDL cholesterol gives more cardiovascular event reduction according to number of years in trials and comorbid conditions as well. As you can see, as the trial duration is longer, we see that there is more a reduction in the risk of reduction in the cardiovascular disease rate. And you can see as the number of years in trial is more than 6, you can see 36% relative risk reduction compared to somebody who has taken part in a 1-year trial, has got 11% reduction relative risk reduction. So again, this is important in real world practice, because somebody who is taking a cholesterol lowering drug, whether it's a statin or any other drug, the duration is very important. So it's not a drug which has to be started when the patient has got a chest pain, or somebody who has been diagnosed with a coronary artery disease. It has its own role at that point, but ideally the cholesterol lowering drugs should be used are the drugs which are good at primary prevention, or does a great job in primary prevention of cardiovascular disease. So it should be started early, and the cholesterol levels should be checked early, and the longer the patient is on the drug, the more is the protective effect of this drug. So it is there irrespective of whether the patient has got diabetes, metabolic syndrome, and you can see with or without diabetes, this effect is there. And as the duration of the taking drug prolongs, the chances of relative risk reduction is also increased. So management of dyslipidemia is high on priority, and statins are definitely the first line of therapy. Undoubtedly, statins are the first line of therapy in the management of dyslipidemia, irrespective of whether the patients are diabetic or not. But the concern is, do all statin users achieve LDL goals as per the guideline recommendations? So the answer will be a big no, because that's what we see in our clinical practice. It can be due to multiple reasons. It can be due to intolerance to statin. It can be due to suboptimal dosage. It can be due to the adherence of the patient. It can be due to the metabolic factors which produce a suboptimal concentration of statin in the blood. Or it can be because of the suboptimal dosage which is provided by the physician. Very often we see that, especially in the periphery, we see that the dosage is suboptimal. Somebody who is on a 10 milligram of atorvastatin alternate day or twice a week. Again, it is something, if it is recommended by the physician, again, that is suboptimal dosage. So a lot of things are there, which is there in the community or in the practice, which make the LDL goal below what is, which make the LDL goal much above what is suggested. And the second concern is how to achieve LDL target after maximally tolerated dose of statin. So first thing, we have to make sure the patient is on the right dose of statin, on the right titrated dose of statin, and the maximum tolerated dose of statin. There are patients who are still uncontrolled or having high LDL cholesterol levels with the maximum tolerated levels of statin. So what to do in such patients? So we will go to the first concern. Do all statin users achieve LDL cholesterol goals as per the guideline recommendations? This is what this is how the LDL target is based on risk stratification. This is based on the Lipid Association of India Guidelines 2020. You can see the patients, how are the patients classified into low risk, moderate, high risk, very high risk, and extremely high risk categories. You can see the risk factors and markers for high risk. Again, major ASCVD risk factors like age more than 45 in males and 55 in females. I would consider this to be 5 years or 10 years younger in the Asian or the Indian population. Family history of premature ASCVD is a very, very important thing which you have to get from the history. Very often we see patients who have a father or a mother who has got a premature ASCVD. Somebody has got an angioplasty done at 50 years, or somebody has suffered from a stroke at 55 years, a parent who has suffered from an event. So these patients are at very high risk of cardiovascular event at a younger age than, a much younger age than what their parents suffered. So it should always be asked in the history. And cigarette smoking and tobacco use in any form, we know the associated risk. High blood pressure and low HDL cholesterol is additional risk factors. Other risk factors with our diabetes, definitely it is a very major risk factor for atherosclerotic cardiovascular disease, CKD stages 3 and 4, familial hypercholesterolemia, and any risk factor when it comes to the extreme, it becomes a major risk factor. And the coronary calcium scores more than 300, non-stenotic carotid plaque, lipoprotein A more than 50. All these are additional risk factors. And what are the non-conventional risk factors? A calcium score of even 100 to 299, increased carotid intima media thickness, the lipoprotein A level of 20 to 49. Even an impaired fasting glucose, a patient with pre-diabetes is thought to be at higher risk of getting NIS-AVD, and increased waist circumference as a part of the metabolic syndrome, and an HSCRP more than 2. All these are non-conventional risk factors. So based on the presence of or absence of risk factors, and based on the number of risk factors, the Lipid Association of India has classified patients into low risk, moderate risk, high risk, very high risk, and extremely high risk categories. So this is something which should be read in detail. This slide is again available free to be downloaded from the Lipidology journal. And these are the LAI 2020 revised targets for the Indian population. So extremely high risk group, as we discussed, the optimal LDL cholesterol goal is less than 50, and category A, this is for the category A, and the category B, you can see CAD with more than one feature of very high risk group, or recurrent ACS within 1 year despite an LDL of 50. It is very rare, but there are occasional patients who come like that, and in these patients it is recommended that the LDL is less than 30. And coming to the very high risk, moderate risk, and low risk, the LDL is thought to be. This is the treatment goal. This is not the level at which therapy is to be initiated. This is the treatment goal, and the target is thought to be less than 100. So generally, you can see that even in the low risk patients, it is recommended that the LDL should be less than 100. And correspondingly, if you can add a 30 to that, you will get the non-HDL goals. There are some set of thoughts that non-HDL is a better marker than the LDL cholesterol, but again, most of the data is, which are available is with LDL cholesterol. And you can consider drug therapy. These are the targets for considering drug therapy. Again, if it is more than 30 in the extremely high risk group, more than 70 in the high risk, and more than 130 in the low risk group, you can consider starting a statin. So this is how the targets have changed from 2016 to 2019. We have newer agents coming into the market. We have newer studies with the older agents which have been there, which have shown to be more promising. And we have studies which have shown that lowering the LDL level beyond the previous margins have got additional benefit of cardiovascular reduction in the cardiovascular mortality. So a patient who was considered to be okay with an LDL of 115, as per the 2019, the target has been brought down to less than 100. And very high risk patient, again from less than 70, it has come down to less than 55. So as the cardiovascular risk increases, there is need to reduce more LDL cholesterol. So based on the revised ESC 2019 guidelines, how many patients do we have controlled LDL? So it's very nice to read about the data and project everything in the PowerPoint slides, but what is happening in the reality? So that is of more concern. So this is the cross-sectional observational study of lipid modifying therapy used in secondary and primary care. This is the Da Vinci study. Again, it's a cross-sectional observational study. In 18 countries of Europe were involved, including almost 6,000 patients and close to 3,000 patients on primary prevention, and almost similar numbers in secondary prevention. And the objective was to evaluate the impact of ESC 2019 dyslipidemia management guideline on LDL-C goal achievement. And you can see, as we expect, 27.6% eligible patients are receiving high intensity statin. Only 27% are receiving high intensity statin, and only 30% patients achieved lipid goals with high intensity statin. So even with a high intensity statin, there are a good number of patients who are remaining uncontrolled, or who are having uncontrolled lipid levels. So that shows the sad state of affairs. So that could be one of the reasons why we are seeing more number of patients with acute coronary syndrome, and many of them being on statin, already on statin, but the target is not achieved. Just being on a statin doesn't provide you comprehensive risk reduction. And again, statin usage, the previous slide was in all patients. And if you select the high-risk patients only, again, you can see that 37.5% eligible patients were receiving high-intensity statins. And of that, only 22% patients achieved lipid goal with high-intensity statin. Again, a good number of patients remain uncontrolled with higher lipid levels. So this is my own work, which I published in IDF 2019, because I strongly believe that data from our part of the world, or the area where we are practicing, has got more relevance than studies done somewhere in the Europe or in the Africa. And this is a similar study which we published in the IDF 2019, where we looked at 424 patients who were admitted with an acute coronary syndrome, and we actually looked at the diabetic status of these patients. And again, you can see that these are the overall study characteristics. And it's very important to see these two tables. You can see in those patients with previous history of diabetes, where we expect these patients to be on a statin. Almost all patients are expected to be on a statin, and the target LDL of less than 100 is what is thought to be ideal. At least in the majority of patients, you can see that only half of these patients were on statin. And almost more than 76% of these patients had an LDL of more than 100. So which means that vast majority of the patients with diabetes, who are virtually considered to be a CVD equivalent, who require statin use in 99% of the cases, and who require an LDL cholesterol of less than 100, are having very high uncontrolled levels. And
Hello, sir. Sir, one minute. Prashanth sir is stuck up now. Satish ji?
Yes.
that is the if you don't touch
Okay.
third of the patients are on statin.
Sir, your voice was breaking, sir. Now it is okay. Satish ji, doctor is there.
Okay.
Yes. Can you please once again share screen?
Yeah, and is it okay now?
Yes, sir.
Okay. Sorry. So I apologize for the network issue. So I think I was I had stopped on those patients who were on who were admitted with an ACS, and who were not on not having a history of previous diabetes. Again, you can see that only 1/3 of patients were on statin, and 90% of these patients were having a high LDL cholesterol. So there is a huge burden of patients with uncontrolled dyslipidemia. All these patients are prone for an acute coronary or a cerebrovascular event, or any atherosclerotic cardiovascular event. So it's very important to screen these patients for dyslipidemia, start them on statins, and if these patients are not tolerating statins, or not able to, we are not able to reach the target with the maximum dose of statin, then add on the second agent and make sure that these patients are brought below the recommended target levels. So how to achieve LDL targets after the maximum tolerated dose of statin? That is the topic for discussion today. So how to be effective with lipid lowering therapy in very high risk patients. So it has got a very important, this is a very important topic because we every day we see patients getting admitted with acute coronary syndrome. Thanks to the development of the development in the field of cardiovascular disease, in the field of cardiology, we have cath labs at every 10 or 15 kilometers, which has made things life much easier for the patients. More and more people are reaching the center in time, and the door-to-needle time has decreased. But still, these are a large chunk of these patients can be prevented from getting an event by proper providing proper statin. So you can see that despite a large number of patients coming with dyslipidemia, again, you can see if you look at the baseline LDL level, and you can see the ASCVD risk, and there are patients with established ASCVD, familial hypercholesterolemia, and complete statin intolerance. So good number of patients are having have a requirement beyond the conventional statin therapy. So high intensity statin has got low adherence, which leads to higher MACE events. Again, that is one of the problems. When somebody sees a 40 milligram of statin, they will tell that it's a very high dose. It can cause side effects, irrespective of whether the patient has got its effect or not, side effect or not. It is thought to be a very high dose, and very often the patient himself reduces the dose to 50%, makes a 40 milligram statin will be made to a 20 or 10 milligram statin, and again it will be suboptimal therapy. And this is again another observational study of close to 24,000 patients post ACS who were prescribed high intensity statin after an index event, that is secondary prevention. And you can see that 66.4% of all these patients presenting with ACS did not take high intensity statin after discharge. It's a wonderful revelation that almost 2/3 of patients are not on the secondary prevention dose, and more than 50% of patients had drug interruption at the end of their therapy within first month after the index event. Again, that increases the risk for second event. And non-adherence to high intensity statin had strong association with higher mortality by 60%. So we will now come to the topic proper, bemtoic acid, which is an ATP citrate lyase inhibitor, which is a first-in-class LDL lowering drug, which has got a mechanism of action, and we will go into the mechanism of action in the coming slides. So what are the approved indications for bemtoic acid? It will reduce the uncontrolled LDL cholesterol level in patients with maximum tolerated statin dose, and also in patients with mixed dyslipidemia, familial hypercholesterolemia, and high risk of ASCVD event. And statin intolerance, or whom in patients with statin intolerance or whom in statin is contraindicated. So dose is 180 milligram orally with or without food. So this is the timeline of the studies which were done with bemtoic acid. All these things started with the US FDA approval in February 2020, then the EMA approval in March 2020, followed by various the drug coming into the various guidelines in the last year. By August, the Lipid Association India had taken up bemtoic acid. In October, the ACC was recommending the drug. In March 2023, we are having the clear outcomes, and in April 23, it is recommended by the ILEP, which is the International Lipid Expert Panel. So a lot of things have happened in the last couple of years on this drug. And this is a novel. This has got a novel mechanism of action which acts upstream the HMG-CoA reductase. It acts one step above the HMG-CoA reductase by inhibiting the ACL enzyme, and thereby it decreases the production of HMG-CoA, and thereby reducing the LDL cholesterol level. And an important thing to note is that this is not activated in the skeletal muscle, as ACSVL1 is not expressed in the skeletal muscle. So the skeletal muscle related side effects are comparatively less compared to the statins. So management of patients receiving bemtoic acid therapy. So there are a few things to be noted when the patient is being given bemtoic acid as as with any medicine which is used in the modern medicine. If the medicine has got some effects, some mechanism of action, there should be some side effects which should be monitored and which should be looked for while prescribing to the patient. And the dose of the drug and the therapy should be tailored according to the side effect profile of the patient, or whatever side effects if the patient has. So this drug has got a half-life of 21 hours, and elimination of 70% excretion of the dose through the kidney, and 5% excretion through the feces, and less than 2% excretion of unchanged drug through the kidney. So it doesn't require any dose adjustment in CKD unless the patient is in end-stage renal disease, or the patient has got child class C cirrhosis. So in moderate to mild CKD and chronic liver disease, the patient doesn't need any dose adjustment. And one of the side effects is hyperuricemia. So all patients assess serum uric acid when clinically indicated, especially those patients who are having a borderline or elevated uric acid. There can be some increases in the uric acid level. And you have to be vigilant in patients who have a previous history of gout, because this is known to increase the uric acid levels. And especially in patients more than 60 years of age taking corticosteroids or fluoroquinolones, again with renal failure, multiple risk factors, you should look for a history of tendon rupture, because these are the other drugs which are associated with tendon rupture. So in association with other drugs which puts the patient at a risk of tendon rupture, if you give a bemtoic acid, there can be an associated tendon rupture. But again, very unlikely that patients are on a prolonged dose of fluoroquinolones. There are patients who might require prolonged dose of steroids, especially those who are on the COPD patients or the rheumatology patients who are on long-term steroids. But again, these are the patients probably they should be given in those patients where bemtoic acid should be used with caution. So they should be warned of a potential for tendon rupture and advise patients to rest at first sign of tendinitis or tendon rupture. And again, who are the patients who should be discontinuing the therapy? In patients who are more than 60 years taking corticosteroids or fluoroquinolone with renal failure and an existing history of tendon rupture, you have to discontinue the drug. And if the patient is taking simvastatin more than 20 milligram or pravastatin more than 40, avoid concomitant use of bemtoic acid and consider lowering dose or switching the statin, because again, the side effects can be higher, and it is not approved in pregnancy and breastfeeding. So otherwise, it has got a relatively safe profile. So this is the CLEAR outcome trial. Again, the cholesterol lowering via bemtoic acid and ACL inhibiting regimen, which was published a couple of months ago. It was published in the NEJM few months ago. Again, this trial was headed by Steve Nissen. Steve Nissen is very well known for his controversial publication on rosiglitazone and heart failure, which triggered the cardiovascular outcome trials in patients with diabetes. And the same is heading this bemtoic and can see in statin intolerant patients with elevated LDL cholesterol. So this is basically on primary and secondary prevention patients with elevated LDL cholesterol and statin intolerance. This is the study methodology. The primary endpoint was effect of bemtoic acid versus placebo on 4-component MACE. And the study looked at CV death, non-fatal MI, non-fatal stroke, and coronary revascularization as the primary endpoints. And it had 13,970 patients, almost 14,000 patients in the phase 3 clinical trial, and a median follow-up of 40 months, that is almost 3.5 years. So this is the background. You can see we know that statin intolerance occurs in 15% of treated patients on statins, and which prevents patients from achieving LDL cholesterol levels and achieving the cardiovascular benefits. Bemtoic acid is an ATP citrate lyase inhibitor, and bemtoic acid has been approved for LDL cholesterol, but the CV outcomes have not been assessed. So that was the background for the study, the CLEAR trial. So these were the primary and key secondary endpoints. The primary 4-component MACE, as we know, the cardiovascular death, the coronary revascularization, the non-fatal stroke, and non-fatal MI, and the hierarchical testing for key secondary endpoints. Again, the 3-component MACE, fatal and non-fatal MI, coronary revascularization, fatal and non-fatal stroke, cardiovascular death, and all-cause mortality. So these were the hierarchical testing for the key secondary endpoints. So these were sequentially tested. So these are the demographic data in the patient in the placebo arm and the bemtoic acid arm. Both the arms are comparable. And you can see the primary results. There is a relative risk reduction of 13% when it comes to 4-point MACE, and 15% in 3-point MACE, fatal or non-fatal MI reduction by 23%, and the coronary revascularization by 19%. The p-value being less than 0.05, it is significant. So again, all these data are showing that the drug is effective compared to placebo. So this is the effect of trial regimens on cardiovascular events. Among statin intolerant patients, treatment with bemtoic acid was associated with lower risk of 4-component MACE, 3-component MACE. All the primary endpoints were satisfied. MI and coronary revascularization was also less. And that too in these particular percentage risk reduction. And if you consider the other endpoints like the LDL cholesterol reduction and the hsCRP reduction, again there was 21.7% in LDL cholesterol reduction, despite the patient being on maximally tolerated statin therapy, and 22% reduction in the hsCRP levels. And the safety analysis, you can see almost all the factors are comparable in both arms. Like the major things to look at are the discontinuation rates, which is the same. The myalgia, discontinuation due to myalgia, all these things are less. And there is no change in diabetes. It doesn't increase the percentage of diabetes. There are data which show that bemtoic acid actually might be reducing the chances of developing diabetes and reducing the chances of developing a fatty liver, or reduces. It is helpful in reducing the non-alcoholic steatohepatitis. Early studies are available. At least animal studies are available. There is no increased renal impairment. There is slight increase in the hyperuricemia, which is expected. And there is a slight change in the baseline uric acid level at the end of 6 months. Again, what we have to see is that there is no discontinuation because of the adverse events, and it is similar to the placebo. So this is the conclusion of the CLEAR outcome study. Bemtoic acid becomes the first ACL inhibitor and the first oral non-statin to demonstrate statistically significant reduction in MACE-4 events in patients with or who are at high risk of ASCVD and with documented statin intolerance and elevated LDL cholesterol. So this is the conclusion from today's lecture, and which is actually based on the CLEAR outcome. It is an effective alternative for statin intolerant patients. It is well tolerated in a mixed population of primary and secondary prevention in patients unable or unwilling to take statins. And LDL and hsCRP reduction has been documented. A significant reduction of 21% LDL cholesterol reduction and hsCRP. And there is definitely a small incidence in the decrease of gout, and that should be taken care of, and patients with pre-existing risk factors should be prescribed carefully. And primary and secondary endpoints have been achieved in this particular CLEAR study, and it is an effective approach. It is an effective approach to reduce the major cardiovascular events in statin intolerance patients. At least we have some drug which has shown its capability to reduce the events in patients who are intolerant to statins or who cannot tolerate the dose of statin, or somebody who is not willing to take statin for some reason. So thank you all for the patient listening. Thank you, Silas, for providing this slides, very useful, informative slides. I think if there are any questions, we can take up the questions.
Thank you so much, sir. It was a wonderful session, to the point, and you have already cleared all our doubts on bempedoic acid through the lenses of clear outcomes trial. There are a few questions. There's one question is, as per clinical trial data, is it more beneficial to use bempedoic acid in pre-diabetes patient or to delay new onset of diabetes? That is one question which is there.
One of the earlier trials with bempedoic acid has shown that it reduces the chances of patients getting into diabetes from the pre-diabetes stages, but it has to be documented with larger trials. Right now, it is not indicated. It doesn't have such an indication. But if it has got, it has definitely. If it has got such an indication, it will be a boon, because there are controversies with statin, and there are data with statin which shows that higher dose of statin has a tendency to increase diabetes. At least theoretically, it can precipitate diabetes or convert a pre-diabetic patient into diabetes. So if you have a drug which reduces the chances of patient getting into diabetes, it will be very beneficial, because we know that even a pre-diabetic state is puts the patient at high risk of a cardiovascular event.
Thank you so much, sir. There's one question. You initially were talking about ESC 2019 guidelines. So there's a question related to that how low one can target LDL cholesterol, and are there any complications, neurological complications, which are seen at 30 milligram per deciliter?
Yeah, this was one of the concerns with lowering cholesterol. Still, I see many patients coming and telling that the neurologist have asked to reduce the dose of cholesterol tablet because they feel that it increases the risk of stroke. There was a concern, and there were few articles in the previous years which supported that the lowering of LDL cholesterol to such a low level could put the patient at risk of cerebrovascular bleed or something similar incidents. But later studies, at least in the last 2 or 3 years, we have got plenty of trials which have made patients achieve LDL targets of less than 30 or less than 50, and these studies have not shown an increase in the cardiovascular in the stroke. So probably the earlier trials were based on weaker evidence, or earlier reports were based on weaker evidence that high intensity statins will cause IC bleed or stroke. But later trials which have been done with different agents which have targeted lower cholesterol levels for ASCVD prevention have not shown such levels. So
Yes, sir.
none of the latest guidelines ask to reduce the dose of statin or reduce the LDL or elevate the LDL target just for the risk of stroke.
Even I heard that a newborn baby is having the LDL cholesterol is 30 milligram per deciliter. So that is one more fact I was having along with me. This next question, sir. If my patient is diabetes, he is a smoker, he is hypertensive patient, and if I am considering option of LDL cholesterol reduction, how much LDL cholesterol reduction should I target for this kind of patient? And of course, there was one slide I remember, sir.
Yeah.
You talked about LAI guideline stratification of risk of patients. So how you assess the patients, how you set targets for this kind of patients, and is there any usage of bempedoic acid you have in clinical practice?
Yeah, again, that slide, lipid association slide, was self-explanatory. It actually gives a very detailed data on the classification of risk stratification of patients to be considered for lipid lowering. And most of the patients with diabetes, hypertension, who are smokers, will be either a moderate or high risk category. They will not be a low risk category. So they will definitely require an LDL cholesterol level of less than 100. In selected cases, we have to go for an LDL cholesterol of less than 70. I would, my personal preference nowadays is an LDL cholesterol of less than 70, because we see many patients, even with an LDL of 100 or 90, they are getting a cardiovascular event. There could be multiple factors, but there are only very few things which we can control from our side. As a clinician, we have to offer the best possible treatment to the patient and make sure that we control the modifiable risk factors. There are things which are beyond our control, but if you find that the patient is at a very high risk or a high risk of a cardiovascular event, multiple risk factors, smoking, the lifestyle is bad, the patient has got a family history of cardiac event, premature cardiac event, diabetes is there, no physical activity, stress is there. All these are risk factors which are one by one increasing the risk of an event. So these patients, from the clinician side, the only thing we can do is to control the modifiable risk factors. So control the diabetes, control the hypertension, and put the patient on a high intensity statin. And always better to start with a higher dose of statin and see the amount of reduction in LDL cholesterol. So if it is much beyond what you expect, then you can reduce the dose of the drug. Again, bemtoic acid, as per the current guidelines, it is indicated in statin intolerant patients. So most of my patients who come to me are having decent control with the higher dose of statin. Most of these patients will be landing up in the cardiac unit. Most of these patients with uncontrolled lipid levels, most of them will be detected to have statin, the lipid levels beyond the statin control in the cardiac unit when they end up with an event. So it is very difficult to screen in the general physician clinic. 9 out of 10 patients will be responding to statin. But if you pick up one patient who is not responding to statin or not responding to the conventional line of lipid management, these patients should definitely be put on bemtoic acid. Mainly because you are preventing a major event, and we have the evidence that you're preventing a major event, and you are making the patient in a safe zone with a drug which has got lesser side effects. You can reduce the dose of statin and add on this drug to prevent further side effect of the drug.
This last question, doctor is being asked about when in ACS patient can we use bempedoic acid? So what is your take on?
Again, the initial line of management in ACS patient remains the same. It has not changed. Again, as the guidelines clearly tell you, if the patient has got an cardiovascular event, then the first line of treatment is definitely statin. It should be 80 milligram of atorvastatin or a 40 milligram of rosuvastatin. And if the patient is not intolerant, if you see that the creatinine levels are rising with 40 milligram, the CPK levels are rising, the patient has got elevation of liver enzymes with an 80 milligram of statin, but the patient has to get an LDL of less than 50. Some patients, even for an LDL of less than 70 or 50, we need a higher intensity statin. So if that is not tolerated, again, you can reduce the dose of statin to 40 milligram, rosuvastatin to 20 milligram, or an atorvastatin to 40 or 20 milligram, and add on a bemtoic acid. So that is where it is indicated that the patient is intolerant to the maximum dose of statin. So I think I have put the right answer.
Right, sir.
Yes, sir. So before we conclude our session, it was indeed a pleasure having you on this CLEARTalk evening, clearing all our doubts on bempedoic acid. Before we conclude, before we give vote of thanks, any concluding remarks for our delegates from your side?
Yeah, my concluding remark as a general physician and diabetologist, my concluding remark will be to prevent the patient from getting a cardiovascular event. So the main message is screening patients for dyslipidemia and starting the therapy earlier. You have to convince the patient about the need for starting therapy in patients with dyslipidemia. And naturally, statin will be the first drug of choice. And if the patient is not getting controlled on statin, we have got, or if for some reason, if the patient is not willing to take a statin, you have something which is something, a different drug to offer, which was not there previously. So as I showed in my slide, which in the study which I did, you can see huge number of patients are coming with uncontrolled lipid levels. These patients are not coming to the general medicine OPD. These patients are coming to the cardiovascular cardiology department with an acute coronary syndrome. Only then we realize that even though most of them are on statins, they are uncontrolled. So very important to put the patient on the maximum dose of statin and make sure that the target LDL for that particular patient is achieved. So screen for cholesterol, start on the right dose of statin, and monitor the patient and follow up the patient and make sure that the LDL target is met. Unless if the target is not met, titrate the dose or add on the new agent like bemdoic acid, which is available for use with this.
Thank you so much, sir. For vote of thanks, I would like to hand over this session to Suresh.
Yeah, sir. Sir, good evening, sir. Good evening, all the delegates, sir. Yes, I, Suresh Kumar, is really privileged to propose the vote of thanks, and especially I express my sincere thanks to Dr. Prashanth Shankarji, who is a young, dynamic, and one of the most prolific practitioner in Pathanamthitta district. And sir has shared many stages, almost more than 300 forums here. He's always live. And I sincerely thank for accepting our invitation and helping us organize this knowledge sharing platform, sir. Thank you very much. And I express my thanks to all the delegates for joining us and making this session very interactive. I express my thanks to all my senior colleagues, especially to Satish ji, for helping us and organize this program and coordinating it very well. And I express my thanks to Priyanka and team for coordinating this program very well. Once again, my very sincere thanks to Dr. Prashanth Shankarji. And in future also, we will be counting on you, sir, for organizing various such knowledge sharing platforms. Thank you, sir.